Often when we talk about anticoagulants, we often refer to this as keeping the plumbing clear. Numerous arterial pathologies such as myocardial infarct, strokes, and peripheral ischemia, and venous pathologies such as deep vein thrombosis and pulmonary embolism basically happens when an occlusion happens or a stenotic lesion happens. Now, under normal circumstances, blood clot formation or hemostasis and breakdown, fibrinolysis, usually happens in a physiological continuum. Unfortunately, when this physiological continuum is upset, this leads to thrombi, which can have severe consequences. As a result, one has to understand the biochemical and the physiological mechanisms that underlie blood clotting. As a result, there are a number of factors that are involved in clotting. First, let's look at some relevant terms. Hemostasis is the cessation of blood loss from a damaged vessel. Thrombosis is a pathological formation of a hemostatic plug, and a thrombus is a blood clot that forms within a vessel and stays there. Arterial thrombus will consist mainly of platelets and leukocytes within the fibrin meshwork, and a venous thrombus is similar in composition to a blood clot with a jelly-like red tail. An embolism is all or part of a thrombus that becomes dislodged and moves to a distant site. Fibrinolysis is a normal body process that normally prevents blood coagulation and from excessive growth. Now, coagulation basically is the formation of a thrombus that involves platelet reactions and blood coagulation. Platelet reactions are on the left side of the figure and often involves platelet adhesion, and that generally leads to platelet irrigation, and what stimulates blood coagulation is ADP, thromboxane A2, serotonin, calcium, and certain platelet factors. There is the extrinsic pathway of blood coagulation. It begins with the release of tissue factors and activation of a number of factors and calcium. The intrinsic pathway begins with the activation of proenzymes through contact with thrombin. The coagulation cascade begins with the extrinsic factor is much faster and the intrinsic factor is much slower, and this leads to the proteolytic conversion of prothrombin to thrombin. Once fibrinogen is converted by thrombin to insoluble fibrin, it is the job of fibrin to form a meshwork on the platelet plug, and this basically reinforces platelet plug. Antithrombin is the process of thrombus formation that is highly regulated. It's a serine protease inhibitor that inactivates the thrombin, basically factor 2, and is aided by protein C and S particularly. Now, if you look at the coagulation cascade, vitamin K, which is one of the important factors, has to be converted from the epoxide form back to a reactive hydroquinone, and this is required for the carboxylation and activation of the coagulation factor molecules. This is particularly what is inhibited by warfarin. So the three ways drugs affect hemostasis and thrombosis is basically blood coagulation of fibrin formation, platelet function, and basically fibrin removal. Now, the process of hemostasis in a nutshell comprises of three major important interrelated steps: blood vessel constriction, platelet plug formation, and then ultimately clotting. Injury to blood vessels causes platelet activation. That releases the vasoconstrictors, which is ADP, thromboxane A2, and serotonin. As soon as you have vascular constriction, you have collagen underlying the vessel endothelium becoming exposed. Once the collagen is exposed, this is responsible for platelet adherence and aggregation to form a platelet plug. Once the platelets are activated, you will expose glycoprotein 2b3a, which is a receptor site for fibrinogen. This allows the fibrinogen to attach and then ultimately to form a fibrin clot. As a result, a number of the antiplatelet drugs are able to inhibit a number of these factors. As a result, formation of the fibrin clot basically reinforces the platelet plug. proteolysis of the fibrin meshwork will remove the platelet plug. Anticoagulants are used as primary prevention, antiplatelets for secondary, and fibrinolytics basically to dissolve the clot. So you have heparins, which are indirect thrombin inhibitors, you have vitamin K antagonists, and then you have direct thrombin inhibitors. The heparins are low molecular weight heparin, the unfractionated large molecular weight heparin, and the synthetic form. The vitamin K antagonists are basically warfarin, and the direct thrombin inhibitors basically are leperidine, bivalirudin, synthetic argatoban. Now, heparin basically is either the large molecular weight heparin or the low molecular weight heparin. Typically, the way heparin acts, heparin or unfractionated heparin is a very large molecular weight. It binds to antithrombin 3, and by binding to antithrombin 3, it inhibits the activation of the coagulation factors, particularly factor 2. As soon as it binds to antithrombin 3, it causes a conformational change, and that opens the reactive site of antithrombin 3 and subsequently increases its ability to inhibit coagulation factors by at least 1,000-fold. So heparin is used for the treatment of venous thrombosis. It's a first-line agent for anticoagulation in patients who have DVT, pulmonary embolism, and myocardial infarctions. It is also used in preventing post-operative DVT and PE in high-risk patients, including during pregnancy. There is a need for continuous infusion of heparin, unfortunately. The pharmacokinetics of heparin is that it's a very large molecular size substance. It has a very short half-life, therefore requiring frequent administration. It is extremely quickly metabolized by heparinase in the liver, and it is degraded in the periphery by endothelial cells. For this particular reason, patient response is quite variable. The next thing is that heparin is very highly and non-specifically bound to plasma proteins, which makes it a candidate for drug interactions. It is associated with toxicity, which is bleeding, and the major problem is bleeding, and therefore you need very tight dosage control, and particularly bovine preparations may cause allergy. Chronic use is associated with osteoporosis. The next problem is HIT, or heparin-induced thrombocytopenia, which is rare but creates a serious problem and generally occurs 2 to 14 days after beginning therapy with high molecular weight heparin. Heparin overdose is always treated with its antagonist protamine, and protamine will antagonize the effects of heparin very quickly. The direct thrombin inhibitors, leperidine, is a recombinant form of hiridine, and then you have the monovalent agents argatoban. They will cause hemorrhages, and leperidine is contraindicated in renal insufficiency, and argatoban is contraindicated in hepatic insufficiency. They are primarily used in heparin-induced thrombocytopenia. They are the drugs of choice in the treatment of heparin-induced thrombocytopenia. And the drug selection is often based on the presence of renal or hepatic insufficiency. Warfarin, which is basically Coumadin, is basically considered to be an oral anticoagulant, and it is specifically a vitamin K antagonist. You will not see the full clotting properties of warfarin 4 to 5 days after you commence therapy. Therefore, the effects of warfarin late for 4 to 5 days because it takes a while for it to inhibit the factors. Specifically, what warfarin does is inhibits factors 2, 7, 9, and 10. As a result, because it is inhibiting factors 2, 7, 9, and 10, it will take 4 to 5 days to completely inhibit these clotting factors. Now, more specifically, it inhibits the synthesis of vitamin K dependent clotting factors 2, 7, 9, and 10. However, the synthesis of these clotting factors requires carboxylation. That carboxylation process utilizes vitamin K. In this process, vitamin K becomes oxidized, and in order to be regenerated, it needs to be reduced. This reduction process is facilitated by the enzyme epoxide reductase. Warfarin specifically